Hello, everyone. This is Anna Maria Toronto, Vice President of Marketing at Cincy. Welcome to today's webinar, which will highlight tomorrow's rehabilitation, a virtual environment. All attendees are muted during today's presentation. If you have questions at any point during the presentation, please feel free to type your question into the chat window on your control panel. At the conclusion of the webinar, we will review the questions and our featured presenter will answer them. Please note that today's presentation is being recorded. A link to the recorded webinar will be sent to all registrants and attendees after our webinar. Today, I'm pleased to welcome Jason Peoples, Virtual Health Developer at Mary Free Bed Rehabilitation. He will share his insights on this interesting and insightful topic with us.
Thank you, Anna Marie. My name is Jason Peoples, and I lead our virtual care efforts at Mary Free Bed Rehabilitation Hospital. I have been in the telehealth space for the last 9 years and came from an acute care system previously and worked with a lot of different service lines in a lot of different areas across the continuum of care, looking at things from inpatient to ED to being able to fill gaps in services in rural areas, as well as looking at what beyond acute care can be. So what we're looking at now is the post-acute environment in the rehabilitation space. So a little bit about Mary Free Bed. Let's advance to the next slide. Mary Free Bed is located in West Michigan. The main campus is in Grand Rapids. We have 167 inpatient beds, and we provide rehabilitation care throughout the network, which stretches across Michigan, and we have relationships with other acute care systems and manage an additional 192 beds across the state of Michigan. Next slide. During fiscal year 2018, we treated nearly 42,000 patients across the continuum of care and are on track to eclipse that number this year. Next slide. And some of our marketing campaigns, really when we talk about rehabilitation, this is about returning to form and function. So our mantra is restoring hope and freedom. And as you can see from our outdoor advertising, our patients walk out on us. So that's a pretty unique marketing approach and really talking about returning form and function to our patients. So next slide. Objectives today, we're going to be talking about what the definition of telehealth and telemedicine is. Definition of the originating site where the patient can be at time of service, definition of the distant site practitioner, as well as the risk and compliance considerations related to telehealth. Next slide. So when we look at telehealth, we talk about access challenges, and this comes across as a myriad of different service lines across post-acute as well as the acute care, and just really being able to access care in general. So if we flip the paradigm around and we really think about this from a patient perspective, we look at limited mobility, long-term treatment, complex care, and provider shortages. These are all real-world examples of the challenges that we face as patients and looking at being consumers of choice and being able to look at where can we receive that right level of care at the right time, no matter where I can be. So in the healthcare environment, looking at, okay, if we want to be patient-centered, we really want to focus on how we can provide access to those patients. Historically, healthcare has been very much brick and mortar, so patients coming into your facility. And in the on-demand world that we live in today, being able to work with Amazon and place an order through Amazon Prime, we can get a box shipped to us within 2 days. Healthcare is a little bit different than that, but we have seen quite a shift in those on-demand services, so we're going to get into that just a little bit later. So next slide. Telehealth adoption. This is just a chart that we wanted to have as a diagram to really kind of frame what we're talking about here. So if you look at 2015 going across the board, there was about a 35% telehealth adoption, and that pulls together physicians, healthcare systems, as well as patient adoption. So there's a lot of opportunity that we see. And if we fast forward to 2018, we're right above 45%, so right in the 46, 47% mark. And I think that's really interesting because telehealth means a lot of different things to a lot of different people. Some healthcare systems are just now looking into what telehealth can be. Even at Mary Freebed, when I joined, Mary Freebed was providing telehealth, but it was really focused on the remote patient monitoring environment, but was branded under telehealth, more of that general overarching banner of what telehealth is. So I think it's really interesting that a lot of these technologies are together and they're really patient focused. So that's really, I think, one of the key points to take away is to think about being innovative and being able to, again, deliver that care in a way and in a format that people, patients, consumers really demand. Next slide. So we talk about what we have today. We look at empowering our patients. When we send a text message on our phone, we expect a response back relatively quickly, unless it's just an FYI. So what if we leveraged a tool that people, patients, consumers already own? And these powerful tools are on these mobile devices we have, these phones. So these phones have sensors. We have alerts and notifications. We have our calendar and schedule. We can send messages. We have GPS, video camera, as well as phone, which is really what that core functionality is. But we look at this as a tool that we have in the palm of our hand, in our pocket, in our purse, somewhere that we feel tethered to. There's a moment of panic when we don't have our phones. So how do we leverage tools that we already have in the healthcare environment and really shift that onto patient empowerment? So it's fantastic to be able to pick up the phone and call your healthcare provider. That's been tried and true for many, many years. Well, with the ability to be able to snap a picture with your camera, send that into your healthcare provider, how does that get into the medical record? So the technology is here, and it's really exciting because we are empowered. We have this technology, and it's been a challenge for the healthcare systems to embrace that technology and integrate that into the way that care is delivered. So next slide. So we talk about consumer expectations. We look at large telehealth companies that provide resources in addition to the platforms and technologies, American Well, Teladoc, MD Live. These are all companies that really have focused more of those on-demand services. And these platforms have the ability to have your providers available as well as the platform for patients, almost like a portal. But what we looked at Mary Freebed was really identifying some of the large leaders in the nation with the platforms, what they're doing, what some of these resources are. And what we have seen is that there is a desire in the post-acute space in particular in really having one of those mesh networks of being able to provide a virtual service in addition to those inpatient services. In-person services, I should say. So when we look at some of the technology companies coming in to disrupt healthcare, we have companies like Apple who is coming in and they have built amazing devices, even with the Apple Watch Series 4, being able to have a heart monitor on that device, and that functionality is FDA approved. That is very empowering, and that is an incredible function that we have that we can go to the Apple Store or to Target or to somewhere else and purchase that device. Uber Health, another technology company that's really coming in, that's disrupting the status quo in healthcare. And you think about what Uber Health is, and when you think about Uber, it really is a transportation service. So Uber had said, hey, transportation services, this is what we do. This is what we do well. So what if we were able to partner with healthcare systems and provide a HIPAA-compliant patient transport solution for certain patients? So that is something that is very easy. It's almost low-hanging fruit when you think about it, being able to call on demand with the healthcare system and provide transportation for those physician visits, for those follow-up visits, whether those are therapy or other service-driven, but being able to provide that service as a way to continue the engagement of the patient so that we can reduce the no-show rates and have better patient compliance and ultimately better outcomes and patient satisfaction. So additional healthcare disruptors, we look at what Amazon has come in and done. Amazon has provided the backbone with their AWS servers. There's a lot of healthcare systems and technology companies that are using the AWS servers strictly for the backbone for that infrastructure. That's something that without Amazon doing that, we would be looking at having a lot of in-house technology servers that would be in-house, that would be on-prem, that we would have to manage. We would have to look at what the support is for those devices. So actually farming that out to a company that has major data centers that we can partner with makes a tremendous amount of sense. And then moving forward, really looking at what those customer expectations are and looking at what we would be able to do to provide services to patients anytime, any place, anywhere with a device that has a network connection. So that led us down the pathway with really looking at the power of utilizing a platform like Cinzy, being able just to do that, being able to provide any care, any place, anywhere with the person with an internet-enabled device with a network connection. So that was very attractive to us as we were looking to scale our virtual care efforts and being able to look at not Mary Free Bed having providers that are just on demand, waiting for a call to come through. Being able to, we in rehabilitation in the post-acute space, we don't work with the patient populations with the coughs, the sinus infections, the bronchitis, the allergies, the red eye, a rash, something like that, that you really know what you have already, but I don't want to go sit in an urgent care clinic for 60 minutes with 50 other sick people. I want to be able to access this care on demand. In the post-acute space and rehabilitation, those are not the patients that we deal with. So a lot of what we do is really physical medicine. So we want to return the patient to a form of independence. And it would be unique case by case, but really taking that into account and really focusing on the patient and what their needs are and providing access to care to them as a scalable solution is what led us down this pathway. Next slide. So when we think about integrating technology into the healthcare system, not every single technology implementation as a solution really needs to be viewed as a huge enterprise-wide deployment, such as an EMR. So, we think smart. We want to think about the virtual care, the technologies that would be the backbone to provide these services, as well as EMR platforms and other compatible solutions. Data warehouse is another term that is thrown out a lot, being able to aggregate that data from somewhere and then being able to pull that data and provide those analytics and make the most informed decision based on the trends that we see. So we talk about the technologies. We want those technologies really to be seamless. This has to work consistently and reliably every single time. We want to reduce the stigma of just one more thing I have to do. And I think we all can agree when something doesn't work, there's a sense of frustration. And from a patient perspective, if you think about being able to access care virtually, if it doesn't work, there's a broken connection and there's frustration not only from the patient, but from the consulting provider as well. So we want to make sure that we streamline those processes, use technologies that are simplified, easy to use, and consistent. Other areas of opportunity, we talk about think smart. Bundled payments provide the huge opportunity with less reliance on what fee-for-service can be. So think about if we were able to do a total knee or joint replacement and being able to partner with healthcare payers to be able to say, hey, based on this bundled payment, it forces the healthcare systems to look at how innovative we can be with the care that we deliver and being more efficient, because we're not as necessarily worried about what that fee for service is. We're capturing that bundled payment anyway. So I think that's certainly an opportunity that can be explored and look at further innovations as we shift away from that fee for service environment. Additional thinking smart, we look at what the efficiencies are. We look at the workflow. We want to make virtual care as seamless as an in-person visit, and sometimes a better experience in those in-person visits, because it's simply patient access and physician accountability to be able to make that connection with that patient. The way that Mary Free Bed has established these efficiencies is really looking at being able to have established patients with our physicians, with our providers, with our therapists, with our case managers, with our navigators, to be able to connect with those patients any time, any place, anywhere, and integrate that into the workflow so that it becomes seamless. Also, thinking smart, we look at the patient portal. Most EMR platforms, if not all of them, have a patient portal functionality. So being able to access your healthcare information, or being able to send a secure message, or being able to request portions of your medical record to be taken to another healthcare system or another provider. These are all empowering tools and technologies that really think about shifting the paradigm again, focusing on the patient and what their needs are, and being able to deliver on those promises that we keep. So let's go to the next slide. So telehealth defined. Telehealth refers to the broader definition of healthcare that does not always involve clinical services. And I think that's really interesting, because a lot of confusion comes in with telehealth, virtual medicine, telemedicine. But the way that I have really looked at telehealth is that broader definition, kind of that over-encompassing banner of some of these other services that live under the telehealth banner. So telemedicine, we look at that as the use of medical information exchanged from one site to another via electronic communication to provide a patient's clinical health status. So traditionally, we look at what telemedicine could be in that clinical environment. So it could be point to point, along with that audio and video interaction where we're exchanging health information from one point to another. A lot of this historically has happened in the brick and mortar type buildings. There's diagnostic equipment that can be tied in with some of these to match the technology with the needs of the service line. Heart and lung sounds can be done in real time by using an electronic stethoscope. There are otoscopes. There are other devices that can be incorporated into the use of telemedicine to exchange that information from one point to another point. Remote patient monitoring. This is a type of ambulatory healthcare where patients use mobile medical devices to perform a routine test and send the test data to a healthcare professional in real time. So there is a lot of technology companies out there that are looking at remote patient monitoring. We touched on the Apple Watch previously, but there are other companies that are providing simple off-the-shelf products that can be very consumer-centric. So we talk about something like a smart scale or a smart blood pressure cuff that is a patient is able to step on that scale and have that information be securely transmitted to a cloud. Clinician is able to pull that information from the cloud, review that information, and perhaps have an intervention or a conversation with Mrs. Smith, who may not have stepped on her smart scale in the last 4 days, being able to monitor that and say, hey, Mrs. Smith, is there, I noticed this, is there anything wrong? What can we do to work with you? Are you experiencing any issues, any conditions that we should be aware of? We want to be able to have that earlier intervention and really direct you to the right care at the right place at the right time, versus more of the historical reactionary field in medicine where something happens to us and we need to react to it. We need to do something about it. So we think about preventive medicine in the remote patient monitoring realm. Next slide. So with this diagram here, we talk about the different devices. We look at our smartwatches that can be talking to our smartphones, which then can have that information sent up to the cloud. Information can be accessed on your computer, and there's an ability for the clinicians, whether that's nurses or if it's a case manager or a physician, a mid-level, would be able to pull that information down and have a smile on that clinician's face because they're receiving more of the full picture versus just one little slice of it. So I think the beautiful part of remote patient monitoring, again, goes to being able to empower those patients to have that more proactive lifestyle versus just a reaction. So people being able to monitor their blood pressure, monitor their glucose levels, being able to track their calorie intake, and really look at that in a way that can impact and change that behavior. Next slide. Further telehealth defined virtual health. This is something that is a term that's really come out in the last 5 years or so, where, I look at where telemedicine, telehealth has been historically, and we're seeing a shift to more of that virtual care, virtual health realm, and that's really skating to where the puck is going. So again, with virtual health, we look at this as the integration of telehealth initiatives in mainstream care delivery to improve access and affordability across the continuum of care. Again, very similar to telehealth, very similar to telemedicine, but just more of a general term. And I think with virtual, really thinking about, again, anytime, any place, anywhere, that's the empowerment of virtual health. E-health, so this could be viewed as electronic health, again, kind of bundled in under the telehealth umbrella, is healthcare practice supported by electronic processes and communication, including mobile health or m-health. So as we talk about this information, this communication being on these mobile devices or these wearable devices, that all pulls in with the mobile health and the electronic health, which again flows under the telehealth banner. So historically, the American Telemedicine Association has considered the terms telemedicine, telehealth, e-health, and virtual health as interchangeable terms, which again really drives to where the confusion is. But I think, really developing what the baseline is and what these terms are as defined, I think helps clear some of those muddy waters. Next slide. So we're going to talk about mHealth for a few minutes here, and we're going to look at mobile health. So when I think of mobile, I think of being on the go. I think of my mobile device, my smartphone, being able to be that tool, just that we talked about, being able to pull out and have access to my data that I can share with different healthcare providers, share with my spouse, share with my loved ones as needed. But we look at mHealth, and the Apple Watch is certainly a device that we look at as a mobile device and a wearable. In addition to that, we have Fitbits, and even looking at iPhones. This iPhone historically has a case that you can slide on it that has a 2-lead for ECG. Being able to just empower patients to be able to have that for somebody who has cardiac issues. I think that's certainly empowering. And even something as simple as a pedometer can be looked at as mHealth as well. So we look at additional applications that have been developed for mobile health. So this all ties right in with the App Store and or Google Play, looking at how many apps are available. Some of these applications can be physician recommended. There's over 165,000 health-related apps, and those can all be pulled from the App Store and or Google Play, and you're looking at things that can be simplified like medication management. You're looking at things, again, like calorie tracking. You're looking at things that could be activities and games that would be associated perhaps with a stroke patient, where you're talking about cognitive memory. You're looking at things like gait and being able to have interactions on these devices, kind of the gamifying of some of these healthcare educational materials that are out there that we have built into the palm of our hand. The FDA approval for medical device apps, there is FDA approval for some of these apps. Now, it's not widespread necessarily, so I would caution looking at certain apps that may not be FDA approved, but there are best practice applications that are available on these platforms that are clinician recommended, they are physician recommended, they are therapist recommended. So these are tools that can, again, not only empower your clinical staff, but again, in turn, educate and empower those patients to be able to have access to that information on the go or at home after they've had their in-person therapy visit. I want to have a quick refresher on a certain activity. Those can all be driven by your therapist, by your clinical staff, just looking at different ways to empower those patients to have access to help engagement and then again with the better outcomes. Next slide. So CMS graciously publishes guidelines every year, and these guidelines really provide the framework of who can provide the service, where the patient can be at time of service, and what those services are. So again, with these CMS guidelines, this is what Medicare reimbursement would look like. We're seeing a lot of lateral movement in the states as we continue to query our payers. I typically recommend querying your payers every 6 months or so. Those medical policies, they do change, and the contracts that the healthcare systems have with the payers definitely differ from organization to organization and then across the state and then across state lines in particular. So next slide. So the distant site practitioner is defined by CMS as who can provide the service. So we're going to list out the practitioners that can provide these services here. So we look at the physicians, nurse practitioners, so we have a lot of mid-levels that are able to provide services in a telehealth, clinical nurse specialists, and clinical psychologists and clinical social workers. So these are all providers under the CMS guidelines that can legitimately provide a telehealth service and bill and receive reimbursement for these services. So there is a myriad of providers that can provide these services, but we're also seeing some gaps. In the rehabilitation setting and post-acute, we don't see therapy on here in any capacity. So what we have found is that certain states have enacted legislation that allow reimbursement for therapy services, whether that's occupational therapy or physical therapy or speech, and have those services not only be billable, but have reimbursement by state payers. So that's something that we're seeing more traction of as time goes on. So I believe New York State and Missouri are the only 2 states that have enacted that legislation. So there's a lot of work to do, but certainly the more utilization, the more cases that we can build for delivering this technology and really focusing on what's best for the patient, and then being able to partner with those payers and do some studies and say, hey, it may be less expensive for us to provide this service remotely versus an in-person visit. So is there an avenue that we can explore that would be beneficial for all parties and really, again, be patient-centered? Next slide. Oh, dietitians are on there too. So the originating site, this is where the patient can be at time of service for, again, under the CMS guidelines. So again, we look at this as a brick and mortar building. So this would be a physician or practitioner office, hospital, critical access hospital, which is 25 beds or less, rural health clinic, federally qualified health centers, skilled nursing facilities, as well as community mental health centers. So again, you look at that brick and mortar building where patient can be at time of service, very similar workflow and experience as an in-person visit, but being able to interact with their provider in a remote setting. What you do not see on this list is a patient's home. So also with the originating site, there's a CPT code that has been established, Q3014, and that's the originating site fee. So this is a nominal fee that a host site can elect to basically charge the CPT code for hosting the patient at time of service. I believe the Medicare allowable is somewhere around $25.25. Don't quote me on that, but it really fluctuates right around that baseline. Some of the third-party payers will reimburse more for that. Some of the payers don't reimburse for that service at all. So I would, again, stress that you query your payers on the reimbursement for that particular code, and in addition to other telehealth services in your market. But there is an ability to bill for the originating site fee, which offsets some of the cost for any of the staff that may be acting as an extension of that consulting provider. So next slide. So reimbursement for telehealth services, virtual care, we look at this, 4 different ways. So Medicare, there is some reimbursement for Medicare. Medicaid, there is some reimbursement for Medicaid as well. Commercial payers, this is where we're seeing quite a bit of lateral movement in the states. And again, stressing to query your payers. This is something that we do pretty consistently and look at what commercial payers are reimbursing for telehealth services. And they typically follow what the Medicare guidelines are, but there is forward momentum. And we think about some of the vertically integrated healthcare systems who also have a payer involved with their healthcare system. And the initiatives with some of those vertically integrated systems being able to provide primary care access, what they are doing is they are starting to find, again, that patients can be treated at home with a high level of care, prevent an unnecessary visit to an urgent care center or a convenient care clinic or perhaps even an ED, because at 2 a.m. I know that they're open and I just want a prescription for my sinus infection. I've had enough of this. That being able to partner with those payers for the reimbursement, even for services outside of a designated originating site, which would be home, or it could be at work, or it doesn't stipulate where the patient needs to be necessarily. So we're seeing a lot of movement in that arena with the rise of the on-demand services really focused on those acute conditions. And then, of course, for telehealth payments, there's always the out-of-pocket payments as well. So this would be something that could be a copay for anything that one of your commercial payers does not reimburse for, or if it's simply just not a reimbursable service, this is something that you can establish with certain CPT codes to be able to provide an out-of-pocket payment for the patient to have that service at that time. So we've seen everything from $20 to $49. That seems to be the sweet spot with some of the other systems that are providing on-demand services, such as American Well or MedNow, some of those other platforms like that. Next slide. So Interstate Compact, I wanted to share this with the group because I think that this is really interesting and something that is certainly can be on the radar for the future. So the Interstate Compact is something that has been enacted with certain states that are participating right now. As of right now, there has been legislation enacted in 22 states. Legislation has been introduced in 8 states. So what the Interstate Compact does, it really looks at removing some of the barriers and being able to credential and licensing, maybe not credential is the correct term, license different providers across state lines. So if a state is participating in the compact, instead of going through the arduous process of having a separate licensure in another state, there's a discussion that can be held to make that process that much easier. Again, we've got quite a few gray areas in the country here, so there's certainly opportunity, but something to keep on the radar as well as we look at being able to be a national destination for healthcare and some of the larger healthcare systems doing just that, but also knowing that you have to have a provider that's licensed in that state where the patient's location is. So at Mary Free Bed, we have patients that are student athletes that they go back to Lafayette, Indiana. They go to Purdue. So it provides an ethical dilemma for some of our clinicians because they want to continue to treat that patient. So if patient goes to Lafayette, Indiana, goes back to Purdue, they're technically, they absolutely are in the state of Indiana. So being able to have a doc provide a level of service to that patient, it's really where the patient's location is. So a physician would need to be licensed in the state where the patient is at time of service. So going back to some of the on-demand services such as American Well and Teladoc, the way that those companies are able to provide a comprehensive 24/7, 365 service no matter where you are in the United States, then what they're doing is you're pulling from a pool of providers that are licensed in that state. So you've got maybe 15 physicians that are licensed in Illinois, or perhaps it's a much greater amount than that. But if you are in Illinois at time of service and you're in Chicago visiting and you get red eye and you want to be able to pull from an on-demand service, you would be pulling from a pool of providers that are licensed in that state. So next slide. So really we want to talk about some of the more granular details here and really focus on the use cases. So this diagram really illustrates, the adoption rate for inpatients, which is 63%. So a lot of the top use cases are really focused on, hospital consults or tele-ICU, tele-sitter monitoring. So that's a real scenario where we look at being able to think smart, leverage our resources a little bit differently. But there's also the ability to have an awareness of what services are not available. We know how difficult it is for physician recruiting, just in general across the board, let alone certain specialty services. So there typically are hubs in different areas in those acute care systems where you're able to provide more of those comprehensive services because you have a deep team of physicians that are able to work with their colleagues and provide those services. So thinking about, again, how do we improve availability of our specialty care? This would be a way that, again, we look at eliminating the distance as a barrier to provide those services, and there's certainly a pathway to do that in a virtual environment. So in the outpatient setting, we talk about 45% adoption rate, and again, something looking at post-discharge follow-up visits. So again, these could be established patients that you've already seen, have that relationship with, and want to connect with them either in a brick and mortar building or perhaps even at home. So other outpatient initiatives, we look at expanding coverage, reduce those no-shows. How do we minimize the no-shows? So, in Michigan where we are, we get a lot of snow in the winter, and we have patients, as much as we think Grand Rapids is the center of the universe, it really isn't. And thinking again about how we can deliver that care to the patients that need it the most and are unable to travel because of weather, or they're unable to pull their child out of school to come for a physician and or a therapy visit. So how do we do that? The virtual way is certainly a pathway to do just that. And then in primary care, direct-to-consumer virtual visits, I think we've touched on that quite a bit, and looking at, again, those acute care conditions that can be treated quick electronically and not have a need to come in for an in-person visit. So also in primary care, you're seeing things, as we talked about, as preventative care and being more aware of what your conditions may be with the advent of mHealth and these devices and sensors we have built into the devices on our wrists or in our phone. There's a lot of opportunity there that we've just starting to scratch the surface with what that will look like. And then also retail and competitive threats. So we hear about Walmart, we hear about CVS entering this market and being able to not only pick up your prescription, but also be able to have a virtual visit or even a consult with your pharmacist. So these are real world scenarios that are happening today that are driving some patients away from those traditional healthcare systems. So in the emergency room, again, specialty consults, I think telestroke and telecardiology are the two gold stars, for being able to provide access to those underserved areas. And we think about comprehensive stroke in a level 1 trauma and being able to have access to a stroke neurologist, being able to provide guidance with an admitting physician or an attending physician or a hospitalist being able to say, yep, this patient needs TPA. So let's go ahead and get that started. So a lot of healthcare systems do not have access to those resources. So when you don't have access, you either choose not to provide that level of service, or how can we provide that service? So that's where telehealth virtual care comes in to be able to bridge that gap. So we're seeing a lot of common themes as we're talking about these different use cases. And then in the post-acute space, so this is something that is near and dear to me, having been in post-acute for the last two plus years, coming from acute care, looking at a myriad of different avenues and applications that we can really provide a beneficial service to the patient. So adoption rate in post-acute is about 10%. That is, a lot of that has to do with the restrictions that are placed on the rehabilitation space. We take for granted that in physical medicine, we can physically touch that patient, we can maneuver that patient, and that's just the way that the clinicians are trained. So you take the physical medicine out of physical, and it's like, oh my gosh, I don't know what to do. And I think you really need to focus on glass being half full versus half empty, and thinking about what can I do versus what I can't do. How often do I need to touch and feel? Is this something that I can do remotely? So I think that really looking at this as a hybrid of some of the outpatient use cases and pulling that into the post-acute space and saying, okay, what can I do? Can I do a therapy visit with you at home? I can provide oversight, I can provide education to you, and I can view and interact with you. So we're not looking at really replacing those in-person visits for therapy services, but we're really looking at this as a hybrid model to be able to enhance those visits, again, drive that patient engagement, and have them come back for better outcomes. So also in the post-acute space, it's been the least likely to be engaged in virtual care because of the restrictions that are placed basically on CMS. Again, if we're very therapy-driven and there's no reimbursement for therapy, it's like, well, how can I do this? Well, the technology is there to do this. It's just the legislation and those rules and guidelines haven't caught up to the technology being embraced by people, by consumers, by you and I being able to have access to these specialists. So there's a lot of different initiatives that Mary Free Bed has gotten under our belt so far as we've gone down this journey the last 2+ years, and being able to look at where are our gaps in coverage, what service area do we service? Where is our market footprint? We know in West Michigan, where Grand Rapids is, we receive a lot of referrals from all around the state, the Upper Peninsula, cross state lines, as well as being a national destination for patients across the country. So being able to integrate virtual care into the admissions process has been a fantastic avenue and a tool that we can absolutely use to help make the determination of looking at that referral in black and white that we receive from facility A, looking at this referral thinking, oh my gosh, this patient looks like a train wreck. What if we were able to lay eyes and ears in a real-time interaction with that patient, with a Mary Free Bed liaison at the bedside, with one of the attending physicians? Would that paint a different picture of what this referral looks like? What is the discharge plan? That can all be done in a real-time engagement. And those are a lot of the questions that we have when we receive a referral. We want to know more about the discharge plan because we want to know that we're going to be setting this patient up for success. So being able to integrate that into the admissions process has certainly been something that we've been laser focused on and have made great strides since we've introduced this concept, and has really looked at increasing our conversion rate and being able to provide those services remotely. In addition to the admissions process, we have provided direct-to-consumer services for established patients. So we had started this with our pediatric pain physiatrist, who is able to have initial patient contact, patient coming into the office, have that initial discussion with the patient, and schedule a follow-up visit in 2 weeks. But I made a medication change, so I want to check on that patient in 3 days to see how they are reacting to that. So being able to integrate virtual care into the continuum with the outpatient for the pain program for pediatrics in particular has been very, very successful. Again, thinking about patients and parents, pediatric patients, not being able to leave school or to leave work necessarily to pick up their kid from school and bring them to Mary Free Bed for that visit, which doesn't require any hands-on. There's not a physical touch involved in that encounter. So again, thinking differently about how we can deliver care and change the myriad of, I have to touch everybody. Well, there's a lot that you can do. So you think about, again, focusing on what that patient criteria is to fit the bill for a telehealth/virtual care visit. And then maybe it's not for everybody, but the patients that do fit the bill, it's absolutely impactful for those patients, and it's a huge patient satisfier. Next slide. So despite all these challenges, there is certainly opportunity. And I love this quote from Einstein: in the middle of every difficulty lies opportunity. And I think healthcare really hits the nail on the head with with what these opportunities can be. So again, thinking differently about the way that care is delivered. Next slide. So with the opportunities, we really are focused on being patient-centered. We want to talk about improved access, expansion of services, patient access, patient being able to access services in a place and in a format that they demand. We look at the cost efficiencies, cost containment, and cost reduction. This can be anywhere from being able to look at what the overhead is. There's a magical equation that ties in with that with different healthcare systems, but being able to look at how many times a patient is touched throughout the registration process, the follow-up visit, and being able to integrate patient service coordinators as part of that flow, being able to really utilize resources a little bit differently. And I think that all ties in with the bundled payment opportunities as well. So we look at what we traditionally do in the fee-for-service environment and then shifting that to that bundled payment. So again, cost containment can lead to these increased efficiencies because you're not as worried about that fee-for-service. You're able to, again, grab that bundled payment and be innovative and mindful and efficient with the way that that care is delivered and integrated into that model. Additional opportunity, we talk about market share. So where is your healthcare system? Where would you like to expand to? So think about that strategically with services that you may have that may be able to be provided to other partner facilities or affiliates, or even a contracted service with another healthcare system that doesn't have those services available. It is absolutely no problem for a service of a specialty to be provided remotely. That's very, very common, and I think that we just need to shift that paradigm and thinking that that's okay to do that. As much as physician recruiting is really, what we want to drive for, having that physical presence there, it's just not feasible all the time. So being able to expand your services and create more of that brand awareness for those services that your healthcare system is providing, that's something that we at Mary Free Bed have certainly looked to do with our network facilities, as well as our affiliates and partners that we work with all around the state and even across state lines. So other opportunities lie in patient demand. So we look at reduced travel time and patient-related stress. I know that when I go to the physician's office, even if it's for a wellness visit, it's not something that I'm really excited about doing. So could I do this in a different way? Maybe I can. Thinking about if anybody travels a distance. So I know that in West Michigan and historically when I lived in Illinois, people are really, really loyal to their community. And they have been at the mercy of the healthcare systems to get them in when it's convenient for the healthcare system to have an opening for you. So if I'm traveling 30 miles, 40 miles for my follow-up physician visit or my therapy visit, I think about the travel time, the windshield time that it simply takes me. And if this is a complicated case, in rehabilitation, we work with patients that have strokes, brain injuries, spinal cord injuries. Some patients are wheelchair bound, so we really think about the needs of the patients, and the travel can be a painful process, and that patient-related stress as well. So coming to a larger community and thinking about parking and how am I going to get to this visit? How much time do I need to allocate for this? Is this going to be, do I need to take an additional 30 minutes before my visit to not only make the travel time, oh, wait a minute, I've got to park, I've got to get into my visit, I've got to do the registration. So all of a sudden, your 30-minute visit could certainly be 2 to 3 hours out of your day. So if you look at that from the patient perspective, it's not very satisfying, but it's historically the way the healthcare systems have been. So again, we talk about patient demand, being able to access services in settings and formats they demand. In some of these virtual consults that we've done, we've seen patients in a myriad of different areas. So anywhere from at home, even at work. In some cases, we've connected with mom in the car who is in the car getting warm and viewing their kid's soccer game outside. So I think that's kind of funny, but you think about, again, having the power to do this any place, anywhere, as long as you have an internet connection, it's really interesting. Next slide. So the operational piece of what we've been able to really drive into is the integration in the practice. So again, we want this to be an extension of what the providers are already doing. We want to reduce that stigma of just one more thing. And there's some amazing components to the integration into the practice. can be very, very flexible. So, you think about when your physicians, your consulting providers have time to be able to provide these services. Is this something that can be done in the morning? Can it be done before lunch? Can it be done after lunch? Is it done at the end of the day? Or is it simply that a doc has every Tuesday from 1 o'clock to 4 o'clock, I'm just going to do my virtual care visits. So they allocate that time on their schedule to provide those visits in a clinic type setting. Patient criteria is really key. So as these programs are growing and developing, being able to really identify who those champions are, and there's different patient criteria that meet the needs of the service line. So really tailoring that criteria, and I would suggest starting small and really build on those successes. And there is an interest in a slight competition with some of the colleagues that are thinking, hey, my colleague down the hall is doing this. I'm kind of interested in doing this too. So is that something that they would be interested in? So all of a sudden you're building on those successes, you're getting more champions. And again, the technology is crucial because it has to work every single time. It's not so much about the device anymore, but really about those platforms that are secure enough that meet the encryption standard for HIPAA compliance, but also meet the requirements that would be simple and easy to use, not only for the consulting provider, but for the patient too. So additional areas in operation that we look at, we talked about some of the referrals from an inpatient standpoint. So even from outpatient as well, you have different primary care offices that are referring certain patients for your services. Where are those referrals coming from? Where are those gaps in services? Could you provide a service remotely? So you think about that strategically and thinking about, okay, where can I provide these services as a partnership with some of our referring hospital systems or clinics? Additional operations, we look at what the provider engagement is. So there needs to be strategy behind this, and there's a couple different ways to slice the strategy with the providers. A lot of the providers in the clinic setting in particular, they're working on a schedule. So being able to identify those patients that are coming from a distance, is there opportunity to provide a virtual care service to those patients either closer to home or even at home? So do you need all of those patients to come in? Some of them absolutely you do. Other ones maybe not. So again, if we're looking at access and intake, this may be a good strategy to consider and adapt that for the different service lines and the clinicians. Provider engagement really drives with the champions. So having a doc who is engaged and can speak to this program and their successes and help lead those efforts from the physician perspective is huge. It's huge. And having different docs and different service lines being able to champion and speak to the virtual care and their experiences with it, as well as their colleagues, the administration, it speaks volumes as these programs are more grassroots and getting underway. So program development, we touched on that within the strategy piece with the engagement, being able to look at, okay, what are the service lines and what is our strategy? What is our plan of attack? Does everybody come to us? Are we really wanting to grow our business? I think most people are looking to diversify and provide services outside of their local facility or drive more patients into that facility. Well, how do you do that? So you can provide these considerations in the program development. So if this is something, a contract or a service that you're providing to another partner system, being able to have the discussions up front and saying, yes, we want neuropsychology. Oh my gosh, we don't have a neuropsychologist and the facility is 2.5 hours away. Is there a way to do that? Well, the easiest way to do that would be to have your provider to be credentialed at that far site and be able to provide a telehealth service. Next slide. So further diving into the operations, the scheduling, we touched on that a little bit, where this can be as flexible or as rigid as you want it to be. I've worked with some providers that say, every Monday from 1 o'clock to 3 o'clock, I'm going to see 20 patients. And that is pretty incredible. And that's all they do for that 2-hour block. Others are very aggressive. They say, I've got a 30-minute time here. I've got 30 minutes here. This is what my clinic looks like in the morning. And guess what? I want to be able to see my in-person telehealth. So it really is customizable, and we want to tailor that to the provider's needs and be able to integrate that seamlessly. So the documentation piece, we know that if we don't document, it didn't happen. So the documentation for telehealth encounters really are similar to what an in-person encounter can be. So being able to provide some of those best practices like where is the consulting provider at time of service? Where is the patient at the time of service? Putting that perhaps even as a smart phrase in your medical record just as a quick touch and have that pre-populated. So that's something that can all be integrated into the workflow for documentation. The documentation really goes into, what happened in that visit, which is something that we do already. So the coding and the billing, so the CPT codes that CMS provides, the CPT codes are the CPT codes. Historically, there has been a GT modifier to indicate that it's a telehealth service. I think they're shifting away from that as we look forward. But if you're looking to track some of those telehealth visits, being able to include that modifier in the code to be able to pull that data to know that these patients were indeed seen via telehealth, and that's something that could be an indicator for sure. Risk and compliance, we always talk about consent. So is there the ability to integrate virtual care language into an existing consent form? The answer is absolutely yes, for inpatient and for outpatient. Or if you don't want to go through that process, you can develop your own independent consent form. So that's something that we would always want to obtain consent from the patient. That can be documented. It can be, it's always going to be documented, but it can be done by hand, or it can be even a verbal consent if your organizations follow through with some of those processes. And then we talked about what the documentation is. And then we also touched on the credentialing for the doc to be able to have privileges at that facility to provide a billable and reimbursable service. So that's something to take into consideration too. And as the program develops, looking ahead, and this has to go with the strategy, looking at what services can be provided remotely. It can be a tedious process to credential a physician, but it's always a question to have with the medical staff offices to think about, is there a way that we would be able to alleviate that process? If our doc is not going to physically be on site, is this something that we could credential by proxy? That's always a question that you can ask. Productivity, we look at productivity really being the same as an in-person encounter. And operationally, education. So there's always the train the trainer, and that has to go with the physicians, the clinical staff, anybody that's supporting that virtual encounter, being able to provide the education. There's also a piece of this that touches the patient. So what is their expectation? How do they do this? What do they need to know? Is it as easy as touching a button and being able to bridge into your virtual encounter? The answer is it can be that easy. So there's a lot of opportunity, but really driving concise messaging and having some marketing awareness behind that is really the key to the success. And we want to really be concise with what that messaging is so that we can outline what those expectations are, and perhaps even have a script from the doc who is being able to do a virtual encounter for the first time. Is it something that they're looking into the webcam for? Is it something that they've got two screens where they've got the medical record up on one side and they have the voice and video interaction on another side? But having that same etiquette as you would in an in-person visit all ties in with what that education is. Next slide. So engagement. This is a great quote that we had from our CMO. Telehealth is another means that we can reach out and extend the expertise that is in the quaternary rehabilitation facility and extend that reach to the rest of the state and beyond. So this is Dr. Jakubowski, our Chief Medical Officer, and he has been my partner in crime to be able to help share the awareness and work with the physicians to be able to think about how we can integrate this into the way that Mary Free Bed delivers care across the board. So while we look to be very aggressive with our strategy and be able to infiltrate all of our different modalities and services that we deliver, we'll look at telehealth, virtual care being another avenue that we can provide that access. And that wraps up my presentation. So I want to thank everyone for listening and participating in this discussion. And I don't often get to share my passion and my love for virtual care. It's certainly something that is very gratifying for me. And on the innovation side, being able to do something that hasn't been done before is certainly interesting. So thank you.
Great. Thank you very much, Jason, for presenting on today's topic regarding the current and future environment for virtual care and rehabilitation, especially as it pertains to Mary Free Bed's amazing and innovative care. A couple questions that we've received throughout the webinar is, first, understanding your experiences to date in using Cinzy's communication platform. What is the feedback that you've received from providers, from the facility in general, from users, from patients? If you could share with us just some insights in the experiences to date.
The insight's been very good so far, and I think really one of the biggest selling points that I have been able to work with, because as much as I love the strategy and those high-level discussions, really the operations, the boots on the ground on the front lines is what makes the magic happen. So being able to work with your frontline defense, and we have patient service coordinators who are just that. So being able to integrate Cinzy into their workflow. So for example, if I'm a patient and I'm going into the clinic and my physician says, hey, I would like to schedule an in-person visit for you in a month, but I'd really like to connect with you in a couple weeks. So we're going to follow the same process as the patient is being scheduled for that follow-up visit for the in-person, as well as that virtual visit link that can be provided through that Cinzy platform. And to be able to have a patient service coordinator not only go into the medical record to schedule that visit, but also launch Cinzy as a platform to take an additional 60 to 90 seconds, literally, to be right there with the patient to send that patient a communication, whether that's a text or an email, has been hugely beneficial because, again, I look at one more thing that our clinicians, our frontline staff have to do. So by adding an additional 60 seconds, it's really not that big of a deal, and it has worked out very well so far. So with the physicians that have been available to provide the consultative service, it's been very positive. They're like, this is all I have to do. All I have to do is log in and wait for them to call me. Yeah, the answer is yes. It's really, really that easy. So we're looking at being able to enhance the way that we have incorporated Cinzy into the workflow and looking at perhaps virtual care appointment reminders being that first message that is sent, and then sending another message template that has the virtual visit link embedded in it, perhaps the day of that visit, to give the patient the reminder first time and then the second time. So a lot of healthcare systems have different call reminders. Maybe they're robocalls that are done through the medical record, but another pathway that you would be able to provide a message for an appointment reminder or even for educational content. So those are all some of the things that we're dabbling with right now. So the docs experience has been very, very positive, and the feedback has been really, hey, I can connect with anybody. I'm not limited to just one platform. Do they have to be on a Windows machine? Can they do this on their phone? The answer is yes. So that is really the beauty of Cinzy, that we've been able to, really grab that feedback from our clinicians, our docs, and the patients say, hey, this is great.
Great. Thank you for your answer. Another question which has come up is regarding the patient community that you serve at Mary Free Bed. So specifically, one of our participants today wanted to understand more about the patients you serve, if it includes adults as well as children under the age of 21, as well as the different facilities that you also partner with. Does it include other hospitals, post-acute care facilities, SNFs, et cetera?
Mm-hmm. Yeah, the answer to that is yes, and the Mary Free Bed reach is really just that. So having a virtual platform to be able to connect with any of these healthcare systems has been fantastic. So Mary Free Bed has a pretty aggressive growth plan and network that we have established. Some of these network facilities are certainly acute care systems that may have an inpatient rehabilitation unit, and they have partnered with Mary Free Bed to really manage that unit, or perhaps it's even a joint venture. So some of the healthcare systems that Mary Free Bed has partnered with as far as the network, Covenant is probably the largest one that we have partnered with over on closer to the east side of the state in Michigan. So Covenant and Saginaw, they're about 2.5 hours away from us, and being able to look at what the admissions process is, as well as provide inpatient services. So that's certainly an area that has been very, very successful as we have gotten this off the ground the last several months. Other healthcare systems within the Mercy system, there is Mercy Hackley over in the Muskegon area. So that's about 45-ish minutes along the lakeshore, so kind of west and a little bit north over there. Traverse City, we are working on a joint venture with a healthcare system, Munson, and that will be an inpatient unit as well as outpatient services as well. So again, that Traverse City is about 2.5 hours from Grand Rapids. So again, looking at physician recruitment, how can we provide services to those systems where they otherwise wouldn't be available? Virtual care is a compelling pathway to do just that. So a lot of the focus has been on inpatient, but we have just really started to roll in these outpatient services in strategic areas to be able to provide not only therapy services, but what I'm looking at doing is providing physician follow-up services in a similar fashion as looking at, okay, where are our referrals coming from? What is on the doc's patient panel right now? Could these patients be treated closer to home? or even at home. So we look at leveraging those outreach locations and some of those facilities that you may have contracts with or leasing agreements and being able to provide those professional services with, but also have an extension of the providers. So if there was a need for a hands-on type of visit, that could certainly be done in that controlled environment.
Great. Well, thank you, Jason, for presenting again on today's topic. Thank you, everyone, for listening to today's webinar, which was hosted by Cindy. This concludes our presentation for today. A link to the recorded webinar will be sent to all registrants and attendees within the next few days. Cindy is a technology company dedicated to providing better ways for you to manage and engage patients, members, and colleagues simply and efficiently. We go beyond traditional telehealth with our award-winning virtual care communication platform for providers to use to engage their patients, members, and colleagues with video, SMS, text, and/or email. The platform allows virtual visits and virtual consults to be conducted on any smartphone, tablet, or computer, and on any level of cellular Wi-Fi connectivity. We'll be following up with a link to this recording, as well as a link to a video on Mary Free Bed, so you can learn more about the mission, vision, and values of the organization and the communities and patients that they serve. Thank you again.